don't even actually know quite what the laws are for lots of drugs or what the penalties are, but they are shaped heavily by what other people say and what other people consider normal and problematic. So this is the kind of thing you see if you work in psychiatric addiction, is that lives are sort of complicated. I'm just going to read this little vignette to you. So Sally is a 40-year-old accountant who was recently divorced. Her 16-year-old son Richard has seemed sad and low in energy since her marital breakup. Richard smokes marijuana every day, both before and after school. He has trouble sleeping. He's also gained a large amount of weight. Both his friendships and his grades have deteriorated. So you got to think, what's wrong with Richard? I mean, is Richard need a tutor? Does Richard need exercise? Is Richard just having a bad time because his parents got divorced? Is he just going through normal adolescent sadness? Or does he have a cannabis problem? Well, you could make arguments for all those things, and when there's a kind of mishmash like this, as life tends to be, people often talk to other people and say, what do you think is wrong with my son? What do you see? Now, so imagine it's 1985, and you have a mother's movement against cannabis, and everybody's very anti-cannabis. That particular variable is probably going to jump out more in what the neighbors say, and the doctors say, and the teachers say, your son's got a problem with drugs, you need to get into drug treatment. Well, today, as cannabis use is getting banalized, I think is the term in sociology, but it's becoming sort of a non-issue, not worth commenting on. Probably more often these situations you'll get a different explanation. People will say, well, actually, maybe the cannabis is self-medicating his depression. He's probably depressed about the divorce. You should get him on an SSRI. Or maybe he needs a therapist. Or maybe he needs an exercise coach or something like that. But it's surely not the cannabis. And I'm not saying we know what's going on. We usually, in these complex situations, don't know what's exactly going on. But as cannabis is normalized, you would expect through all those social processes, fewer people will seek treatment, even voluntarily, not just because of declines in legal pressure. So now let's move to things that could increase utilization, and the first of those is improved health insurance. So the number one reason why people who have a drug problem in the United States and say, I sought treatment, I didn't get it, is they say I couldn't pay for it. So we have had a revolution in treatment insurance in the last 8 years. There was a parity law passed in 2008, a Medicare improvement, and then the Affordable Care Act, all of which means that tens of millions, probably hundreds of millions of Americans have better coverage than they did before. So more people, if they do in fact have a cannabis use disorder, are going to be able to access treatment. You would think that would raise things. The growth in heavy use, you would think, would raise it. So the harms are going to be concentrated for this drug, I think, as we all know, in people who use a lot, every single day or nearly every single day. That group is growing really, really fast, accounting, in fact, for most of the big increase in consumption. So as that population gets bigger, that's the pool of people who would go into treatment, at least eventually. And then last, increased in adverse effects of cannabis use disorder. Now, a lot of this depends, of course, on how we regulate it. But an interesting phenomenon about regulation in general is, weirdly enough, something's more likely to become harmful if you're sure that it can't. Right? So at the end of alcohol prohibition, Wayne Hall tells me, a lot of people didn't believe cirrhosis of the liver actually was due to alcohol. They'd kind of forgotten that. And lightened up regulation, and then we had a rise of cirrhosis of liver. So to the extent we have a rhetoric that cannabis can't really harm anyone, and then we regulate it in that fashion, keep it really loose, don't really worry about it, weirdly enough, then in fact it's more likely to harm people. So that's going to depend on what our decisions are in that domain and how we make decisions about things like how many outlets, how rigorously are they going to card and try to keep underage people from using, how potent are we going to let the substance get, all those kinds of things. And if state regulators believe, these things it's not a big deal, let's not worry about it, weirdly enough, you could have more consequences. These will take time to accrue. I still expect for the next few years, and even 5 years, it's going to go down. But as those accrue, as more people potentially have a car accident or flunk out of school or that kind of thing, that would then increase the pool of people who needed treatment. Now, last year, the known unknowns, and I'm finishing the specialty. What are the attitudes and practices of employers going to be? That's going to be really important. Are they going to stop testing for cannabis? That would lower utilization. Maybe in some industries, they'll be afraid to test. I don't know if I were running a Silicon Valley company and I was recruiting for young, bright talent, if I would want to test for cannabis, because even if my employers would use it, I may not want that reputation among a certain class of highly creative people. So if employers go soft on this, that would reduce utilization. On the other hand, if these harms accrue, if it gets more potent, if we have a train accident, a bus accident, a big construction site accident on somebody on cannabis, these things can change. If employers ramp up testing and they ramp up the consequences at work, then that would drive treatment. I have no idea which one of those things is going to happen. Oh, and then last, cannabis-impaired driving. So a huge driver, no pun intended, why people seek treatment for drinking is because they've been busted while driving. So we don't have as good technologies to detect cannabis affected driving. We also don't know how prevalent it is and that sort of thing. But one possible outcome you can imagine is that cannabis becomes more like alcohol in that there are a stream of people regularly getting arrested because they're under influence, and the consequence of that is a court says you need to complete this driving class and go talk to a counselor, that kind of thing. So if that happens, then there'll be an increase in treatment seeking, and that really depends on regulation. Look at the states in the U.S., whether it should be a per se standard of when you're intoxicated, or whether it's 5 nanograms per milliliter or whatever, whether there's no standard, that'll have a huge impact on that. So let me summarize what this particular chimpanzee has concluded, throwing cards to the board. To quote the great Yogi Berra, predictions are hard to make, especially about the future. So remember, I basically showed you no evidence at all, it's just ideas. But in the short term, by that I mean 3, 4, 5 years, I would think, you're going to have declining legal pressure and probably, just as importantly, declining social pressure to seek treatment and also to define problems as having something to do with cannabis. So I would expect that utilization curve to keep dropping for a while. But in the longer term, particularly if we're sure it can happen, then it's likely it will go back up again because you're going to get greater heavy use, more allowance of products that are harmful, and also more people experiencing harm, which will then drive them to seek treatment voluntarily. So maybe it will never be as high probably with legal pressure, but some of those people who would have been legally coerced into treatment may end up seeking it on their own. And all of this is going to be shaped by the decisions we make, voters, initiatives, clearly regulation, everything, advertising, marketing that can normalize how treatment is regulated, what employers do, and so on. So there's far more known unknowns than there are known knowns, if that's the right contrast. So anyway, thank you very much.
We acknowledge that there's a spectrum of cannabis use, and I'm going to focus on the medical use today. And in order to talk about the medical use, I think it would help to put it into context of the broader uses of cannabis. And I think that light users, some moderate users, some heavy users, and just like alcohol, there'll be some small percentage of the population that's at risk for abusing cannabis. But unlike alcohol, cannabis has this therapeutic and wellness category, which so far really has been undefined and difficult to talk about and put into context. But it might include adults who seek out treatment for something like insomnia. So they might go to a dispensary and find that they find some cannabis preparation that helps them sleep. They can evaluate the therapeutic benefit versus the potential risks and adverse side events for themselves, and they may decide that it's worth it for that use. And then we have medical use. And medical use is the use of any medication for the treatment of symptoms that you would seek help from a doctor for. And currently there are cannabinoid preparations that have been approved by regulatory agencies in the US, the FDA, in Europe, the European Medicines Agency, and Health Canada. And the approved uses are listed in that category. And I've also included pediatric epilepsy. Some of you might have heard that talk. Those data are coming out this year. So not full approval yet, but very close. So I'm attempting to define these 3 categories, and in order to put medical use into context. But when you think more deeply about the 3 categories, it becomes really complicated because there's therapeutic and wellness use that can actually slip into the recreational category, but also into the medical category. So if we go back to the example of the patient who was using a cannabis preparation for insomnia, if the insomnia becomes so severe that he then seeks treatment from a doctor, that becomes medical use. So it gets complicated, but I think, this is an ongoing discussion that I think requires the input of everyone, and I'm sure this will change over time as we gather more data that will inform each of these 3 categories. And the FDA and other federal health authorities don't recognize it as a legitimate treatment. So this is a problem in my opinion, and I think it's the direct result of a lack of rigorous clinical data and a lack of definition. So medicines by definition have to be chemically defined. right? We need to know what the active ingredient is, or are in the case of cannabis. We need to know how much of that active ingredient is present in the preparation that's being given to the patient. And really importantly, if it's going to be used for medical use, there has to be a reliable and reproducible source. So the patient has to know where to go to get the medicine. Whole flower preparations don't meet these requirements for medical use. In fact, the chemical composition of whole flowers varies greatly from strain to strain. And so we have to get away from this idea that marijuana in general is a medicine because it's not chemically defined. You can chemically define the active ingredients in whole flower preparations, but nobody is currently doing that. Also, whole flower preparations don't have a consistent chemical composition from batch to batch. So even if you do define the active ingredients, unless there's that consistency, it's going to be really hard to use it medically. And you would also need a metered dose inhaler so that the patients can get a defined dose of the active ingredients. So I think you all know that cannabis contains hundreds of compounds, and we really don't understand the physiological relevance of many of these compounds. The two most well-studied compounds are tetrahydrocannabinol, which is THC, and cannabidiol, which is CBD. These are two chemically distinct compounds, and these can be chemically defined in extracts or when synthetically made. And it's possible then via these extracts to make preparations that have a defined chemical composition, they're reproducible, they're reliable, and you can define the active ingredients and then also the dose. But a lot of these extracts or capsule formulations have an inferior method of delivery. So I'll explain that a little bit. The pharmacokinetic profile of any drug is really important to consider when using it medically. And the pharmacokinetic profile refers to how a drug is absorbed, metabolized, distributed, and then excreted from the body. And so any doctor prescribing a medication needs to know these pharmacokinetic parameters. So, and the example I'll give is, on the previous slide, you saw that there's a cannabinoid preparation that's approved for the use of chemotherapy-induced nausea and vomiting. Chemotherapy-induced nausea and vomiting is a serious issue, and it's a cause of morbidity for patients undergoing chemotherapy. And the way it's treated is you take an agent that reduces nausea and vomiting, but you have to take it, so that its onset overlaps with the chemotherapy onset. So there are three purified THC preparations that are FDA approved for the use of chemotherapy-induced nausea and vomiting. But the pharmacokinetic profile is such that there's high inter-individual variability in time to peak effect. So if you know you're going to receive treatment, so chemotherapy at noon, you would like to know when to take the anti-emetic therapy. And so in the case of the approved drugs for chemotherapy-induced nausea and vomiting, that time frame is so variable it makes the drug difficult to use. So we know that with inhalation or pulmonary delivery, that time to peak effect is very well defined. So extracts have some benefits as far as precise definition, but we're still lacking a lot of development and formulations that would make them practically usable. So when you think about the medical use of cannabis, you think about the medical use of any prescription drug. And there's a basic set of data that a doctor needs in order to prescribe the medication confidently. And this basic set of data is outlined here. So doctors need to know what a safe dose and titration schedule looks like. They want to know what a therapeutic or efficacious dose would be. They need a basic safety profile in their specific patient population, not just the healthy population. They also want to know what the side effects are, what the drug-drug interactions are that they should look out for, what the adverse events are. Every drug on the market has adverse events. We need to know what they are for cannabinoids and then what to do in the case of seeing an adverse event. So clearly the path forward has to be through clinical research. I think we would all agree. And I want to make the point with this slide that there are two types of clinical research that we can conduct right now, and they both serve different purposes. So there's the regulatory path, And this is very well laid out. This is, anytime you hear of an FDA-approved trial or a phase 2 trial or a phase 3 trial, that's a trial that's in place to gather data for regulatory approval. So that evaluates whether there's a statistical significance between a placebo and active drug in a given patient population. And the FDA then evaluates that data and either says yes or no to the indication. So we are engaging with 2 groups right now. We have other trials in the pipeline to look at trials like this. Trials like this take years to complete and So the first partnership I want to talk about is with University of Sydney, and we're looking at a new cannabinoid formulation for chemotherapy-induced nausea and vomiting to solve the problem that I talked about earlier. And then the second trial we have undergoing is in partnership with the Ontario Brain Institute, and this is to look at the effects and the efficacy of cannabinoids in adults with refractory epilepsy. So in addition to these regulatory approval trials, we can collect right now data to inform medical use. And this is a different kind of trial, but equally important to us. Because, patients are already using this investigational drug. Physicians would like to know how to recommend treatment. And this data is data that we need right away. So we understand that there are patients out there that cannot wait, 3 to 5 years for the regulatory trials to be completed. And so one mechanism that's in place is an open label trial. And this is a way to get really rigorous clinical data through doctors in specific patient populations on cannabinoid preparations. It requires that the preparations be defined. So it can't be on undefined marijuana, but it can be on any kind of cannabinoid preparation that's defined. And we can also use these open label trials to provide access to patients in other countries where medical marijuana laws might not allow access yet. And we think that's equally important. Another way to collect data is using a database. So while the drug is being prescribed, any drug that's chemically defined, and in fact in Canada, Tilray just received about 4 months ago the ability to make extracts. And when patients take these extracts, they're taking a defined dose. So we can track the use of these extracts in patients, and we can find out information about the dose that's appropriate, the dose that's well tolerated, the dose that actually is therapeutic or efficacious for a certain indication. We can find out information on side effects, and we can find out information on adverse events. This is similar to a pharmacovigilance database, but actually a little bit more in depth. So the current system, I think, fails patients. And this is at the state regulatory system because the state does not adequately regulate the production of cannabinoid preparations. So I happen to have a son with really severe epilepsy. I know he benefits from pure CBD. Today in California, even though cannabis has been legal for medical purposes for 20 years, I would not feel comfortable using any of the artisanal preparations on the market to treat him. That's because they're not safe. They're contaminated. The label doesn't always reflect, or actually often does not reflect what's in the bottle. And I never know if there's going to be, if the same preparation is going to be available months from now when I need it again. And this lack of a safe and reliable products results in a lack of appropriate medical supervision. So in the case of my son, again, I would not want to treat him without the supervision of his pediatric epileptologist. It's a very severe disease. He's on many drugs. And I think you have to be really careful when you're thinking about treating any kind of severe illness. And then, of course, the FDA route has limited accessibility for patients. Right now, we're in the position of doing clinical trials, but it's going to take us years to get the results of these clinical trials. And in the meantime, patients need access now. And I want to emphasize that there are patients who are really sick who need medications now. So 34% of all deaths in childhood are due to epilepsy. So we know children are dying, and if they could potentially benefit from cannabidiol, they need access right now. We know that patients are dying of cancer right now. We know that cannabis and cannabis-derived preparations can improve the quality of life in terminal patients, right? So palliative care is really important. They also need access right now. So now when we go back to the spectrum of cannabis use, I've tried to define the three categories really with the intention of getting everyone on the same page so that when we talk about medical use, everyone understands what that means and what that requires. But I don't want to diminish the importance of the therapeutic and wellness category because patients are accessing cannabis, and it does provide therapeutic value and add to their quality of life. And I think we have to take that category just as seriously. And there are ways to collect data for that category as well. But again, it requires chemical definition of the substance that they're taking. So I just want to end with a plea so a good friend of mine said to me recently, when science gets politicized, rational discourse disappears. And I think we can all agree that the conversation around cannabis is completely irrational right now. And I would just like to end with a plea for more data, and for that data to inform both policy and treatment.
So for those of you who are a little bit unfamiliar with the treatment as prevention policy, I'm just going to give a brief overview before I go into the study. So the treatment for HIV and AIDS, highly active antiretroviral therapy, it does two things. First, it works to slow the natural progression of the disease. So it reduces the rate of HIV and AIDS related morbidity and mortality. And the second thing that it does is that it reduces the level of the virus in the blood to a point where you're essentially unable to transmit the virus onward, and this is called a level of viral suppression. And so back in about the mid-2000s, there was this push towards a more treatment-based prevention policy called treatment as prevention, where the idea is to treat a patient living with interview or administered questionnaire at baseline. They provide a blood sample and then they're followed up every 6 months. Again, they do a follow-up questionnaire and give another blood sample. We can then confidentially link clinical data to the questionnaire data. We can also look at other things like pharmacy dispensation. Two things to keep in mind during the study period: everyone in the province of British Columbia who's HIV positive can have no free HIV and AIDS treatment and care. And treatment as prevention efforts have been ongoing since the year 2003. So the study period was from December 2005 to June 2015. Our two outcomes of interest first were whether or not someone was on antiretroviral therapy. So we looked at pharmacy dispensation records. Second outcome was whether or not they were able to reach viral suppression. And so for this, we looked at the mean viral load count every 6 months. And so they were considered virally suppressed if this mean count was under 50 copies per mil plasma. The main independent variable was self-reported cannabis use that we obtained through our questionnaire. And then we to look at daily cannabis or frequent cannabis use. We then looked at people who use cannabis at least once a day, and those who use cannabis less than once a day or not at all. And for statistical analysis, we did both the bivariable and multivariable logistic models using just generalized estimating equations to account for the repeated measures over time. So between 2005 and June 2015, there were over 800 people in our study. They each provided about 9 interviews. In total, we analyzed over 7,000 interviews for the analysis. Participants were approximately 43 at baseline. 35% of them were women and 45 identified as non-Caucasian. So here we're just showing the proportion of participants in our study who reported either any cannabis use over the study period and daily cannabis use. So the median was 46.5% of participants reported any cannabis use at each 6-month follow-up, and 20.6% reported at least daily use at every 6-month follow-up. So the proportion of participants who were on antiretroviral therapy clearly increased over the study period. At the end, there was almost 100% of participants were engaged on antiretroviral therapy. When we separate this out by whether or not someone was using cannabis at least daily, we can see there's no clear, consistent difference between the rate at which each group is on antiretroviral therapy. And when we look at this statistically, we're confirming this, that the odds of antiretroviral therapy among people who use cannabis at least daily are approximately the same as the odds for those who do not. Again, looking at the proportion of participants who were able to suppress the virus, clearly it has gone up over the study period when we stratify by whether or not someone used cannabis daily. Again, we're finding no clear, consistent difference between the two groups, and when we look at the statistically, we're confirming this, the odds of reaching viral suppression among people who use cannabis at least daily did not differ significantly from those among people who did not use cannabis daily. And I should also note that we wanted to make sure that this finding wasn't due to the fact that we're lumping some cannabis users into our control group, so we also restricted our sample to just cannabis users. We ran our model. We found essentially the same results. And we also looked at any cannabis use versus no cannabis use and also did not find a significant difference. So from this we can conclude that approximately half of our participants used cannabis at each follow-up. About 20% of them used cannabis daily. And the prevalence of cannabis use remained relatively stable over the study period. We observed a significant and substantial increase in antiretroviral therapy engagement and viral suppression over the period. And the likelihood of antiretroviral therapy uptake and viral suppression didn't differ significantly when we looked at patterns of cannabis use. So of course we do have some limitations to the study. First, in generalizing to other populations it might not be possible because of course it's not a random sample. And we do have some unique things in our setting like no cost HIV and AIDS care and this kind of quasi-legal cannabis market, or cannabis framework. We have to rely on self-reported cannabis use. We didn't randomize people who either smoke cannabis or not, so it's not a causal model. And of course, there might be some unmeasured factors in our data that we weren't able to account for. So in conclusion, we did not find evidence to suggest that cannabis use compromises antiretroviral therapy or the likelihood of viral suppression among people who use illicit drugs. And these are two main treatment as prevention benchmarks. So our findings support the continued expansion of the treatment as prevention model to people who use illicit drugs. This is particularly in light of the fact that cannabis will be legal in Canada quite soon. Thank you.
Thank you, Stephanie. Quick question before we transfer.
It's really great research. I'm sorry. I'm finishing my lunch. So, were you able to ascertain whether any of the participants had cannabis use disorder? Because it seems like it was it's just used daily, but not number of times a day, or impact on ability to function or so on.
So we just looked at how the frequency of their cannabis use. First we asked whether or not they had used cannabis, and then we looked at, among people who did, we looked at how often they did, and then we kind of categorized the variable. Unfortunately, because this is just self-reported data, we don't have data on cannabis use disorder, and the other thing is if we were able to look at that, kind of link it with clinical records, there's mental health, especially in this type of population, it's super undiagnosed, like underdiagnosed, so that data would probably be quite inconsistent, but yeah, it would be really interesting to know though. Yeah.
So in today's talk, very briefly, the goal here is to identify the patterns of consumption involving commonly used cannabis products like edibles, smoked combustibles, in a 30-day window among medical cannabis patients. And also to examine the association between these consumption patterns and individual differences to really sort of characterize what are people using, who is using these products, the relationship to kind of key policy relevant variables as well as clinical variables and disease status. And then finally, to briefly, of course, it's a conference on policy, so to talk a little bit about the policy implications of product regulation here in the United States. So our group is really, as I mentioned, very translational, transdisciplinary, and so we're really kind of focusing on building a kind of a human laboratory or collaboratory, as people have often called it, that really bridges the population sciences with the laboratory sciences with the clinical public policy. And so what we're attempting to do really is to, through population science, epidemiology, identify key user groups that are out there, and then feed this into laboratory science, looking at rodent models and primate models to understand sort of validating our models of human consumption, and to see how they replicate in animal models, and then to use those animal models to then do experiments to identify potential long-term disease consequences. And then through public policy, we engage in simulation model, computer simulations, where we take both the population science, the laboratory science, plug it into that big old computer that so it has like big room full of very smart data in there, and then we pop out various clinical simulations. So then we can basically, the end point is to say if we have this type of product that's used in this distribution in the population, we have an understanding of sort of this long-term health consequence that's identified from the laboratory sciences and the emergence of clinical data that are ongoing now. What's that going to do in terms of public policy, both here in the United States and potentially worldwide? So where we are right now is very early stages, obviously. The last couple of years with funding has started to come around to the interest, and so we're really kind of in our first step, which is to develop our characterization of the population sciences. So the present study is a medical cannabis study that we have ongoing here in San Francisco and also Southern California. What I'm going to be talking about is really just a subset of the study. The anthropologist in me thought just one patient was enough to really sort of present this talk. The clinical psychologist in me thought that 50 was a good balance, and the epidemiologist felt that about 500 or so, which is our ultimate target, is really kind of where we want to go. So, I'm kind of schizophrenic in my approach, but I figured sort of the 50 is sort of a good floating point to talk about. So, these data points aren't exactly where the 50 users are located, but rather where they reported getting the dispensaries, and we validate and get a chance to interact with anybody. And I think that's something that, as policy moves forward, we're really going to have to take a look at the public health impacts of that. So how we started to recruit this is we did kind of a mixture of targeted sampling and kind of snowball and convenient sampling. But to make sure that we had a good representation of users, we worked very closely with the dispensaries in San Francisco, and also online advertisements based on Craigslist and in various cannabis websites. Subjects were screened over the phone for age and medical cannabis condition, and then we asked them to come into our offices at RTI, which is kind of centrally located in San Francisco, and we were able to verify their driver's license and also their medical cannabis ID card. And data collection occurred last year on this subsample from May to July on these 50 patients, and of course all the procedures and survey items were approved by RTI IRB, and for anybody who's gone through an IRB on a medical cannabis study, I think the IRB process took longer than the actual study. So once we had our patients and recruited them in, every time somebody came in, we asked them to fill out kind of a pretty intensive battery. We paid them $35 for the study, and then there was an optional sub-study, which I'll talk about in a minute, where they could, quote-unquote, donate some of their medical cannabis for us to test. And I say donate because the IRB would not let us actually pay for a research subject for their marijuana, so we had to donate. So I have to make sure that that's clear, so I don't get in trouble. So what we did was every time somebody came in, we basically gave them kind of a pre-filled form that had the last 30 days that were kind of marked out, and we made sure that we really tailored it so that we made it as easy as possible. We filled in holidays. We asked for really kind of key seminal points that may have happened over the past month, like if there were big events like an election or something. We really tried to make sure that this was a good representation, because going back 30 days, that's certainly not an easy thing to do. We also did a very brief subset where we asked people to come back, and we gave them this retest, and we gave it to them about 5 days later, and the retest was about 90%. 80%. We were 4 for 5 with most of the data that were filled out. So it sort of gave us a preliminary indication that at least what we were doing was in the right track. And then what we asked them to do is we had a little legend here, and we asked them to fill out the number. First of all, starting with the number of times they used, what product that they used, and whether it was for therapeutic motivation, for a euphoric motivation, or for mixed motivation. And kind of in our pilot study, we had a lot of problems with the users because they really oftentimes don't think along those lines of separating out. They kind of say, well, I kind of use it for both. And so we tried to really ask them to say, just think about, when you used that product, really what was your kind of initial motivation for using it. So we tried to force them into a non-mixed category, but of course we wanted to use the mixed category as a key catch-all. So then we used kind of an off-the-shelf test that we actually ended up not continuing on in the study. The data tended to be not very easy to collect and very reliable. And there's a lot of off-the-shelf tests that allow you to basically the kind of qualitatively oriented test. And when I mean qualitative, I don't mean in the qualitative anthropological sense, like you have sort of raw energy data, but more like qualitative as in sort of its very sort of rough benchmarks. And so what the tests do is they give you you kind of distill down through flame the sample, and it kind of boils on parchment paper, and you get these kind of like little circles here. And then you have through the kit kind of a plastic template that has like about 30 different size circles on it. And you kind of superimpose the circle that you think matches up with the result that you're getting on this on the parchment paper. So, if you have a bigger circle, you tend to look at maybe larger levels of, let's say, THC or CBD, and if the smaller circles, then you have a smaller concentration. So, but we just tended to find that the tests weren't easy to administer, and a lot of the research assistants were, really complaining. And so, as PIs, what we try to do is make sure our research staff is happy. So I said, we'll ditch this part of the test. But I think hopefully at some level we're going to try to figure out a better way of re-administering it.